So thank you very much, and thank you very much for joining. And for those who joined first, thank you for coming back to start off with. And for those who have just joined us, thank you, and a big welcome to everybody, and thank you for making me so welcome here in Rzeszów. So we're privileged to be here and to meet members of the department. So I've called this talk, as you can see, recent advances in aging research, and can we slow down the process? And of course, it's all important to all of us, but I think perhaps what's particularly important is thinking about how can we have a quality of life and not just slow down the aging process itself. So just to tell you a little bit about me, so as introduced, I have a long-standing experience base in drug discovery and drug development, particularly in the large biopharma industry, AstraZeneca and GlaxoSmithKline before that. Prior to that, I worked in academia, University of Oxford and Medical Sciences Institute at the University of Dundee in Scotland. And prior to that, my background degrees are in biochemistry. So it's a big pleasure again to try and help explain a little bit about some of the very exciting research that's being done in aging research. Some of this will be familiar to some of you, I'm sure, but hopefully there'll be enough here that you'll find it of general interest. And then I've also included some references if you want to do a little bit of digging yourself. Oops, so I've gone backwards. So just by way of an outline, what I'll go through is just a definition, and a definition principally of longevity, take us through a little bit of an introduction, go through a clinical trials overview of the current status of where we are with selected clinical trials, not everything, of course, otherwise it would be too much to explain in just a short period of time. But introduce you to the concept of senolytics, stem cell therapy, particularly focus on new uses for old drugs, some of which, again, you may be familiar with, but perhaps some of which you'll become less familiar with, but it draws on some very recent research. Think about what the commercial activity and opportunity is, and then think about some future perspectives and summarize, and also I've included a few additional references for you as well. So just by way of a definition, well, what is the definition of longevity? So anti-aging research falls under what's called the longevity umbrella, and really what longevity refers to, this is the classical definition, is it refers to the length of time an individual lives, often focusing on extending lifespan, but I think the most important part is maintaining health and functionality. And of course, we'd all like to live to be a ripe old age, but I don't think that many of us would like to live to be very old if we don't have functional capacity, either physical capacity or mental capacity. And this is quite personal to me, as I'm sure it is to all of us. But my father died when he started to develop early onset dementia, and my mother-in-law in a similar manner. And I suppose the one blessing that I take from that is at least they hadn't developed late-stage dementia, where I know with some of my other relatives where they no longer recognize you for who you are. And I think that's, as I'm sure if you experience this yourself, that's particularly distressing. So aiming to have the quality of life and not just the extended lifespan really has to be the aim of all longevity research. And I think everybody can appreciate that. So if we think of just a little bit of an introduction and accept the fact, well, aging is a complex biological process. And it affects health, and of course it affects longevity, but it's not just a physical process, it's also a mental process. And as you can see here, it really leads to a gradual decline of bodily functions, such that as we know, as we get older, we can't do what we used to be able to do when we were in our actually there's probably quite a few people here who are in their 20s. Well, sorry to say, but when you get older, you may not be able to do what you're able to do today. That's just part of the normal aging process. But we can slow that down, we can at least adapt to it, and we can give ourselves the best chance of keeping that physical ability as we get older. And of course it affects diseases, or it affects organs of the body that can lead diseases such as cardiovascular disease, joint disease, more musculoskeletal disease, and unfortunately to neurodegeneration. And I think Alzheimer's and dementia more generally are some of the great unmet clinical needs that we see in society today. And despite many, many years of effort and research, a true breakthrough in the treatment of dementia, I think, is yet to come. So there is untapped potential there to help people prevent acquiring the symptoms of early stage dementia and leading ultimately to late stage disease. So anti-aging research aims to improve lifespan and health span, of course, and some of the key strategies, and I'm going to mention the ones in green in particular, but also refer to genetic interventions, epigenetic reprogramming, simply because that's a very trendy area at the moment, and I think there is the possibility that I may be back later on in the year to discuss this. We're just going through some ideas now. But I'm going to concentrate on senolytics, on stem cell therapy, on metabolic intervention, which we can do today from drugs that are available today. Mention just briefly microbiome research, but also spend some time on new properties of old drugs. So genetic intervention to start off with. So if we think about genetic intervention, really what are the types of things that we can start to modulate? And genes involved in the aging process have been largely transcription factors, the FOX genes or FOXO genes, sirtuitins, and these genes regulate the stress response that is able to influence cellular repair and ultimately longevity. And it's the cellular repair part that is particularly important when we come to think about senolytics and removing cells that become senescent. And I'll mention that in more depth in a moment. The possibility to gene edit with CRISPR, I'm sure everybody's aware of that. Very exciting technology that's now gone from the lab and now into the clinic. So now being seen as perhaps a new wave of products for the future in more than one disease area, and I'll mention that in more depth later on. So this is where genetic modifications of potentially aging-related genes may occur to ultimately slow down the process. And actually manipulation of some specific genes is now within the grasp of I think, scientists and ultimately physicians. And then studies on lifespan extension in model organisms. Well, certainly back in the 1980s and the early 90s, there was a lot of work done, for example, on telomere shortening, on telomerase as an enzyme, and biotech companies such as Geron, for example, had a number of very exciting programs looking at whether or not telomerase activity could prolong lifespan. It certainly seemed to be the case. Modulation of a number of genes by other organizations showed that lifespan could be extended in model organisms such as yeast, worms, flies, and even mice. So epigenetic reprogramming, and this is a particularly interesting area, very topical at the moment, been around probably since about 2015, so been around for 10 years, but over the last 2 or 3 years, gained a lot more, I think, attractiveness as a research area. So the idea that there are epigenetic clocks that are actually different from the chronological clocks that we all recognize as part of the aging progress. And these epigenetic clocks are regulated by DNA methylation, and there are specific DNA methylation patterns that have been identified and shown to be associated with the aging process. So as you can see here, the measurement of these proteins, and I'll mention some of them in a while, can serve as a way of regulating perhaps the aging process itself. But one of the issues around developing new concepts for anti-aging is that there are no, as yet, regulatory approved surrogate markers of aging. So if you've got a new product and you think it's slowing down the aging process, obviously you want that to be a commercially available and a regulatory approved product. Right now, you would have to show that within a clinical trial framework, which can take and should take a prescribed period of time. It would be very good, of course, if we had a surrogate marker of an anti-aging mechanism that would gain that regulatory approval. That will come in time, but it's not there right now. And such factors such as Yamanaka factors and partial cellular reprogramming, these have been identified transcription factors that have been identified as possible reprogramming factors that, again, I won't go through in depth, but might be the subject of any future talk. The potential risks and promises, well, I think we have to recognize that, of course, if we're delaying what is really seen to be a natural process, the natural process is aging, whether we like it or not, then we do run some risks. And of course, the risks of delaying the natural decay, if you like, and death of cells, the senescence of cells, is that we may inadvertently propagate cells that we would rather die. And of course, that means tumor cells. So there is always the balance, if you like, between the progenerative, if you like, effects of anti-aging versus the effects of anti-aging. And everybody needs to take that into consideration, which of course is part of research and development. So I'm going to start off just by giving a clinical trials overview, and I'll stand back a little bit just so that I can go through this in depth. So the one up at the top, it perhaps comes as no surprise, but omega-3 supplements, which have been available for a long period of time. Fish oil, for example, the fatty acids that you find in oily fish, in walnuts, in flax seeds. These have been around for quite some time. Well, there is now a formal clinical trial being undertaken with vitamin D that there's no doubt has shown some positive benefits. And of course, that's not a huge surprise, I would guess. And as I mentioned this morning, just yesterday, there was a publication in Nature Medicine by Eric Topol and group that have shown in a 30-year follow-up study that the inhibition of chronic diseases in people who are 70 years and older is directly related to diet. And as I'm sure we all know, because we're all told to eat sensibly, that diet includes polyunsaturated fats, and of course fish oils are an example of that. And of course it also includes lack of processed food and red meat and perhaps all of the things that we would normally like to eat. Well, it's probably common sense, but if you're told that you shouldn't eat it on a very regular basis, perhaps society as a whole will gradually adhere to it. So we'll go through this in a little bit of depth in a moment. Senolytic drugs such as dasatinib, quercetin and fisetin, I'll mention those too. So these actually target senescent cells to rejuvenate bodily functions. And these are actually quite interesting because they're to an extent old drugs, or there's drugs that have been used for different indications, and I'll go through some of the data with those. Metformin and rapamycin, well, they're also old drugs, and again, you'll probably be familiar with some of these, but we'll take you through those too. And stem cell preparations, for example, stromal cells that are isolated from vascular fractions, I'll spend a little time on as well. So this is by no means complete, but I think this is quite an interesting snapshot of the current stages of clinical trials in longevity research. So I said I'd mention this to you. So this is a clinical trial conducted here in Switzerland involving, I think it was just under 800 patients, 762 if I remember rightly. And it tells you quite simply that just 1 gram of omega-3 fatty acids over a 3-year period has resulted in a reduction of biological age as approximately 3 months, by approximately 3 months, as measured by DNA methylation markers. So there's a few things to be aware of here. So there's the approximately 3 months to start off with. So that's one thing. So there's an element of uncertainty. It doesn't mean it doesn't work. I believe this data. But also the measurement of DNA methylation markers as a yet to be proven surrogate marker of anti-aging. But I mean, certainly when I was growing up as a young boy, I was always given these by my mother at the time. She took them, my brother took them, my dad didn't take them actually because he didn't necessarily believe in it, but I did. And actually, I don't know whether it's done any good, but it certainly didn't do any harm, and I'm still here. So the role of omega-3 fatty acids, I put this in just for completion. I'm sure everybody recognizes this, that these have wide-ranging properties in terms of reducing triglycerides, lowering blood pressure, all of the things that you would want to happen in your normal life as you get older, which is fine when you're in your 20s and your 30s, but when you're in your 40s, 50s, 60s, 70s and beyond, it's not so easy, and it's not so easy to keep your triglycerides low, your blood pressure in the normal range, and of course have a healthy heart. And it's all about having a healthy heart. And there aren't that many people, I think, that are in their 60s, 70s who aren't taking some form of medication that is precautionary in many cases, but in some cases it's mandatory. And sadly, I know a number of people who are now no longer with us, who refused to take medication because they thought, well, you know, I'm okay. I'm 68 or whatever it is. Yeah, I've had a particularly rough lifestyle, but you know, I'm fine. Nothing's wrong with me. And sadly, with one of my friends, it wasn't that long after I met with him that he had a heart attack and is no longer with us. So there's no doubt about it that as we get older, despite the fact that we may think we're healthy, we're not necessarily, and the seeds for longevity being decreased are sown when you're in your 20s or 30s. So I'm not trying to sound maudlin in any way, but if you have an unhealthy lifestyle and you know what it is, it's not too late to change it. And actually, I would recommend that you do change it because you'll reap the benefit later on. So anti-inflammatory effects of omega-3 fatty acids are also well documented, as is the science behind brain health. And actually, it comes, I think, a little bit around, to me, the concept of mental health and physical health going together. If you feel good in yourself, you will feel physically good. And I can't stress this enough. So having been through this process myself over the years and seen many people who are very stressed, working very hard, they're in a mentally bad place. And if you're in a mentally bad place, you become physically in a mentally bad place. And the two are linked. So with vitamin D and longevity, again, the science is well there, as I'm sure you know. So synthesized in the skin via sunlight, which is fantastic. Not an excuse to go out and get sunburnt, but nevertheless, we do need sunlight to synthesize vitamin D, and again has a profoundly positive effect on the immune system and in chronic disease prevention and in mood and cognitive function. So it makes perfect sense that a clinical study would take these well-known ingredients, if you like, and put them together, and that's exactly what this study did that I was telling you about. So the study objectives were to evaluate vitamin D and omega-3 fatty acids as supplements in people, and look at this in a post-hoc analysis, and the details are here. If you're interested in looking it up, it's the Do Health trial. 777 patients, duration of 3 years. That's the amount of vitamin D and omega-3 that was provided. And the key findings slowed the biological age as measured by these genetic epigenetic markers of DNA methylation. And if you're not familiar with what pheno-age, Grimm age 2 is, which I think is wonderful, and Dunedin pace, I've put in a slide there at the end that you may want to keep as a reference. If you are familiar with it, then you can ignore it. But standardized effect sizes, as you would expect, and combined interventions, as you would expect here. So additional observations showed some influence of aging on a number of other markers. So leptin, tissue inhibitor of metalloproteinase, all processes involved in cellular destruction, and combined interventions also affected biomarkers such as beta-2 microglobulin and GDF15. And again, these are positive biomarkers that we may want to see decline with the aging process. And a subgroup analysis, as you can see here, has shown stronger levels or stronger effects in individuals with lower baseline levels, which is exactly what you'd expect when it's given as a supplement. So I think this is quite interesting in its own right. It probably tells us what we already knew, but nevertheless, this is confirmed in a clinical trial. So I think overall conclusions and interpretations from this. So this has provided, I think, evidence that there is modest benefit. So now, modest benefit, what is modest benefit? Well, as you get older, any benefit is good. So modest may be okay when you're in your 20s, 30s, but actually when you get to be in your 50s, 60s, 70s, modest benefit, yeah, I'll take modest benefit in slowing biological aging over a 3-year period. The combined approach in particular seems to work better than the individual approach. The public health potential is huge there because these are accessible interventions. You can buy these as supplements. This isn't a drug discovery or drug development process, it's already there. You can buy any of these on the high street or online. And it does, I think, guide us towards the potential for future research in larger studies that will be needed to investigate this over the long term. So again, if you're interested in living longer, think about your diet and think about the amount of fat that you eat, and also think about what supplements you may need to take if you don't think that you're getting enough from what you normally eat. I think that's the most important thing. I'm not a huge believer in actually having supplements and then having a bad diet, thinking, well, it's okay, I'm taking a supplement. I don't think that quite cuts it. I think we need to have a diet that's appropriate and supplement it where necessary. So that's just for completion, and won't go through this, but it just helps you understand what some of the science is behind the biomarkers of epigenetic programming, which I think are really quite interesting because this is very much an emerging field, and the field of DNA methylation clocks, I think it's very, very exciting. So I'm going to go through now some of the thinking around senolityks. So what are senolityks? Well, really, senolytics, the definition of senolytics, as you can see here, is that there's really two categories. So suppression of pathological senescence-associated secretory phenotype. And I've put that in full because this is what you'll see in the literature if you look it up. A SASP or SASPs. These are semamorphic, and senolytics selectively address and remove senescent cells. So these are cells that have stopped dividing and contribute to the aging process. So there's two categories, semamorphic and senolytic, and most of the work has been done in the senolytic area. So senescent cells, again, and apologies if you're familiar with the terminology, but maybe not everybody is. Senescent cells are non-dividing cells that secrete this pro-inflammatory SASP repertoire, largely of inflammatory cytokines. Senolytics remove the cells, and the significance is that the accumulation of senescent cells, particularly in the endocrine system, but in any system in the body, contribute towards the aging process. So if we can take out those senescent cells, we'd have the possibility of perhaps of rejuvenating the organs in which they reside. And this is a cartoon here that's taken from a very nice review published just recently that I've put at the bottom here for reference that shows where senescent cells accumulate in various parts of the body. And as you can see, they're widespread. So in the skin, the thyroid, the liver, the adrenals, the pancreas, and as you can see in these glands or in these tissues on the outside. And so that includes also in the bone. So let's think a little bit about what wide-ranging activity we could have if we were able to have an effective, safe senolytic. As you can see, it's very, very widespread indeed. So what's the role of dasatinib and quercetin? And I said I'd mention these because these are relatively, if not very old drugs. So dasatinib is originally a cancer drug, inhibits the tyrosine kinase class of enzymes. So if you're not familiar with tyrosine kinases, these have been involved in a number of inflammatory processes contributing to rheumatoid arthritis, contributing to B-cell lymphoma, many programs around the world targeting tyrosine kinases, one of which I used to work on, the spleen tyrosine kinase, or SYK, S-Y-K, for rheumatoid arthritis. These have been around a long time and a lot of known about these drugs. So these target senescent human fat cell progenitors and in other cell types, and it can help trigger apoptosis or cell death, of course, as you know, in specific senescent cells. Quercetin and also fisatin, which I'll mention at the end, is a natural plant flavonoid. This one is found in apples, onions, and berries, has antioxidant activities and anti-inflammatory activities, as many of these senolytic compounds do, and targets senescent endothelial cells and bone marrow derived cells. So together, these target different types of senescent cells, so it makes sense, I think, as with the omega-3 and vitamin D example, to put these two together and to see, well, let's take these two drugs with a well-known safety profile and let's see what their effect is in a human clinical study. So the objective here, and this is the publication on the right-hand side, was to study these in a simple phase 1, blinded, single-center study, so a small study. And actually the participants that were chosen is patients with stable idiopathic pulmonary fibrosis. So if you're not familiar with IPF as a disease, it's one of the big respiratory diseases for which there are very few effective treatments. That's not to say that there aren't some, but the prognosis for patients with IPF is generally not good. So anything that can help IPF patients have a better quality and a longer life would be very, very welcome indeed, and possibly in addition to the therapies that they would be already given. So intermittent dosing of D and Q, I've called for dasatinib and quercetin, and the outcomes looking at feasibility and tolerability, of course, adverse events and adherence rates, and then exploratory measures of pulmonary and physical function. So remember, this is a phase 1 study, not a phase 2 study. And just to cut a long story short, because I think we've got quite a lot to get through yet, administration was given over a specified period of time, and the outcomes. So this is the bit that gets to be important. The outcomes in particular, well, it does what it said. These drugs do reduce the senescent cell biomarkers in adipose tissue. So they are effective in being senolytics, which is exactly the aim of the study. And the secondary evaluation of the study was looking at a safety and tolerability profile that was acceptable throughout the duration of the study. So that's a phase 1 study. So of course that tells you that at least it's tolerable and it does what it says in terms of reducing senescent cells. The next phase will be to conduct a phase 2 study, and that is being planned at the moment. So that's ticks the box for a number of reasons. First of all, it validates perhaps the use of these drugs as senolytics, because it's reducing the number of senescent cells in adipose tissue in this example, and it also treats a very difficult to treat patient population, patients with idiopathic pulmonary fibrosis. So there's also a study being conducted in patients with diabetic kidney disease. And again, this study has primarily assessed the impact of senescent cells and reduced, again, senescent cells and the tissue burden of adipose tissue senescent cells within 11 days. And as you can see here, detailed results and further research are really going to be necessary. So again, in addition to the IPF study, a study in diabetic kidney disease. So again, if you're familiar with this as an indication, this is a hard one to crack. Patients with diabetic kidney disease, as with IPF, really need effective therapies that are given to them in addition to their standard of care. So I want to mention this also, which is just for completion, which is other clinical trials. So there is a clinical trial at the Mayo Clinic looking at dasatinib and quercetin in postmenopausal women that have shown resulting in improved bone formation and reduced fragility. So again, that tends to suggest that senescent cells in the bone have been removed. The very fact that fragility and bone integrity, if you like, or bone formation has been accentuated, I think gives us great promise. There is a study being conducted at St. Jude's Children's Hospital looking at childhood cancer survivors with the possibility that these two agents may rejuvenate bodily functions and extend their life. And of course, in childhood cancer, anything is beneficial over and above standard of care. And in total, there are over 30 clinical studies that are underway looking at the possible anti-senolytic effects of these two drugs. And I think this is an exciting area to follow and be interested to see how this pans out in the next couple of years, because I think, again, with the availability of both dasatinib and quercetin, there is a potential new therapy on the radar. So I'll put that in just for completion, and the reason I've put that in just for completion, and again it's taken from this publication, is just to mention fisatin. So I'm not going to go through that in much detail, but it's in a similar ilk. It's a plant flavonoid, largely working as an antioxidant. A little bit further along here with a phase 2 randomized double-blind clinical trial. So future directions for senolytics. So I think this in its own right is actually quite interesting, because this starts to make us think that perhaps the senolytic pathway is an effective way to go, and that elimination of senescent cells, albeit cautiously, may have some positive effect. So I think rather than go through this in detail, you can read it. And I'm going to leave these slides with everybody, by the way, so that you can look them up if you want to, because I think there's quite a lot of useful information here that takes you through the background and also takes you through the conclusions. But I think hopefully this has given you a little bit of a framework that senescent cells may be good targets for anti-senolytics, and that senolytics in their own right may be drawn from drugs that we have right now. That doesn't mean to say that there isn't the possibility of finding even better drugs and more effective drugs, but this is validating the concept within the longevity area as an area that's worth further interrogation. What I do want to mention is that the bullet point at the bottom, which is, of course, many of these are available. They're available in the high street, they're available online, but this little bit of caution here is that they lack FDA approval. So if they lack FDA approval, that doesn't mean that they've been through the appropriate strict regulatory process that we would expect. So there is not a drug label, shall we say, for any of these drugs in promoting longevity. And of course, that's ultimately what we want, certainly as drug developers, because we want to know, and we should know, because the general public will take them, these drugs have been through a process, they've been regulatory approved, they do what they're going to say, which is promote longevity. So I'm going to mention now something about stem cell therapy. So stem cell therapy, again, I'm sure many of you are familiar with the role of stem cells in tissue regeneration, and the fact that they have the ability to differentiate into really various, if not any, cell types, aiding in tissue repair and regeneration. This was part of a former life of mine in my research career. The applications in rejuvenization, including MSCs, and I'll mention those in some detail. And then the possibility, I think, of current challenge and ethical concerns, which for sure include the possibility of immune rejection, and of course, ultimately, any of the ethical concerns that I know many people are familiar with, particularly with the use of embryonic stem cells. And again, if you don't even know the stem cell literature very well, I'm sure you're well aware that the use of embryonic stem cells creates a great deal of public alarm, and quite rightly so, if the process is not well defended and well represented and clinically relevant. So just again, giving you some of the background to stem cells, just in case you're not familiar with it. They possess this regenerative potential, utilized in research, which includes embryonic stem cells, as I just mentioned, induced pluripotent stem cells, and mesenchymal stem cells. And the mechanism of action is that they're able to replace, or at least that's the hope, aged or damaged cells, secreting growth factors that can induce tissue regeneration. And I know we have some, there's a regenerative biology department here. I'd love to take and understand your take on the possibility of stem cells in regenerative biology, because I think there's been many cases where they've been used in some very high profile public figures, for example, and not shown to be effective. Perhaps they're being given an unfair test, because it's like any agent, if it's given to somebody as almost a last resort, perhaps the odds are stacked against it being effective in the first place, but I'd love to hear your opinion. The fact that they exhibit immune modulatory effects, of course, can mean the possibility for any disease that is a consequence of immunoinflammation. And when we think about it, well, maybe that's most diseases, certainly rheumatoid arthritis, certainly any atopic dermatitis, most GI diseases, neuroinflammation, they're all part and parcel of an immune inflammatory response. So this study in particular, or this review in particular, published in 2023 by Ricardo Garay, again, I think is a very interesting paper. It summarizes recent clinical trials with stem cells to slow the aging process, and that's where I've taken some of the figures from this paper. So if you want to have a little bit more in-depth understanding of it, please consult this paper, because there's a lot in it that I think you'd find valuable. And again, this just gives you, we won't go through these in detail, you'll be pleased to know, but it just gives you an idea here of some of the large numbers of clinical trials that there are in place. And as you can see, this is with a range of sponsors. It's using stem cells from bone marrow or umbilical cord. It's using, where are we? If I just look around here, it's using different durations of therapy. There's no doubt that there is a lot of work being done to understand the potential of stem cells. And I think this is probably manifest again in stem cell preparations for facial skin aging, because I know that's of interest to the cosmetology department here. A number of studies being done here looking at, in particular, wrinkles, facial rejuvenation. Well, wouldn't we all like that? Again, maybe not you guys, but I might, and somebody else might here. Looking at where are we, photoaging that may happen as a consequence of us all being out in the sun too long. So there's no doubt that there's a lot of interest here in the application of stem cells to what we would regard as being cosmetic appearance, but nevertheless is all integrated in how we feel as people and how we look as people. And that in its own right draws the link back to me between, or one of the links between mental health and physical health. And then just for completion, I've put this one in as well. which again, just for your reference, is looking at a stem cell combination here from the landmark study and also at North Texas University. So where are we with ongoing clinical trials with stem cells? Well, clinical studies are investigating stem cell therapies for this wide ranges, numbers of conditions. Mesenchymal stem cells are frequently studied due to their anti-inflammatory and regenerative effect. And it's perhaps induced pluripotent stem cells that hold the most promise for tissue regeneration, although their current status is primarily in the investigational stage or in the experimental stage. So some notable findings, and again I've tried to draw together various indications and at least give you some of the ideas that stem cell therapies have shown some applications in skin, for example, have shown some improvements in structure, in collagen structure, production, skin elasticity, and wrinkle reduction. Neurodegenerative diseases, again, showed some positive effect, and again in Alzheimer's and in Parkinson's, and also shown positive effects in cardiovascular health, in particularly in enhancing vascular function. So there's no doubt, in my mind at least, that stem cells have a role to play, but by the very nature of them being stem cells, they're not going to be widely available en masse, at least at present, in the same way as perhaps the or the senolytics would be that we talked about in the previous section. So let's have a look. What's the time? I won't go through all of these slides in detail, but this is again taken from this paper published in Frontiers of Aging, here looking at mesenchymal stem cell preparations for aging conditions, and just looking at the conditions here that are measured in physical frailty and in facial skin aging. And as you can see on the right-hand side here, just looking at some of the objectives for both physical frailty and facial skin aging. So it's a very systematic way of evaluating how these formulations are working, albeit in this indication alone. So scientific and ethical challenges, I think this is probably one of the most emotive areas, at least in stem cell biology at present, is the ethical debates around the use of embryonic stem cells, and we mentioned that at the outset. The concerns around tumour formation due to uncontrolled cell proliferation, and this is part and parcel, I think, of the seesaw balance between positive effects and negative effects in the entire field of longevity research, is that if we are looking at agents that stop cells becoming senescent, do we in some way inadvertently promote tumour formation or promote the survival of cells that will become tumours? And there's no doubt that this is one area that really needs to be considered in great depth. And that also applies to the cell therapy area that I'll mention tomorrow. So potential immune rejection, despite advances in induced pluripotent stem cell technology, there is the potential for immune rejection, and again, some of the clinical studies will show this. Regulatory and safety issues, well, stem cell therapy is not yet approved for anti-aging, so they remain largely experimental. So I think there's still some way to go yet, as part of the overall longevity field, if you like. It's very much in its infancy, starting perhaps to become a little bit adolescent. I guess to draw an analogy, we'd like it to stay in the adolescent age and not get too old. But again, we do need it to get to an age where we can see regulatory approval of these therapies before they become released to the general public. And many treatments are offered in unregulated markets. And of course, that raises ethical concerns. And of course, as we all know, can generate some very negative publicity if, for example, an unregulated stem cell therapy is used perhaps in practices that aren't well controlled. And the long-term effects, of course, of stem cell therapies, as with all of these agents, in longevity research are really still under investigation and will be for some years to come. That's the price we pay for working in a new area. So advances in research, and I think this is very interesting, because this is where some of the techniques and some of the new technologies start to merge together. And one of the things is the integration of gene editing technologies and some of the biotechnological approaches that there are now to stem cell therapies, but also to cell therapy in general. So there's no doubt this, I mean, this is almost out of date. I prepared this obviously a week ago or last week. Well, actually, this is almost out of date. I was seeing some feeds just this morning, and I know that there were some papers published over the weekend, and one indeed yesterday, that has already started to move this field on. So this is a very, very rapidly advancing field. Regulatory processes, or regulatory process, but regulatory progress is absolutely critical here. So these ongoing clinical trials need to read out and be subjected to the full regulatory rigor that we would expect for any new therapy to make sure that we've got standardized protocols and we've got standardized procedures. And efforts are constantly underway to develop safer and effective more stem cell therapies. Of course, that goes without saying. So I think, again, my final thought for this part is, while stem cell-based anti-aging therapies show promise, they remain experimental. And I think that's the most important takeaway message for me, is yeah, there's promise, but don't overpromise. And I would say, for anybody working in this area, it's so exciting, but we've got to wait for the science and for the clinical studies to read out before we can start promising. And again, this is I guess it's a throwaway statement, but it's one of caution, is that anybody who's considering such treatments, and there are some available, as I'm sure you recognize, if you look hard enough, really consult healthcare professionals and really understand, but also weigh in your own mind or the minds of friends the potential risks and benefits that there could be from taking an experimental therapy such as stem cell therapy. So I'm going to mention now new uses for old drugs, and metformin in particular. So if you're, again, not familiar with metformin, we'll go through this in some detail, because there's been a lot done on metformin. And again, I've tried to find here the most recent publications to get you right up to speed. Can't get much more up to date than the end of last year. So metformin decelerates biomarkers of aging clocks. So these are the DNA methylation markers that I mentioned. And then there's another one here, decelerates aging clocks in male monkeys. So we're looking at metformin here influencing the aging process in non-human primates, NHPs, which is what that means at the top. So first up, what is metformin? So again, apologies if you know this already, but metformin was first indicated for type 2 diabetes in 1994. It's been investigated for a number of years for its geroprotective or longevity effect, and many studies published on it. This study was, or a study has been conducted in male non-human primates, given this amount for this length of time, and then compared with younger and middle-aged animals. And really the key findings have been that metformin is able to inhibit aging pathways as measured by markers of inflammation, fibrosis, oxidative stress, reacted beneficial pathways, for example, lipid metabolism, DNA repair and Wnt signaling. If you're not familiar with the Wnt pathway, please, by all means, please look it up, because this is a very, very important pathway for regulating the whole of the body clock, and particularly the cell clock. And reduced P21 positive cells, which impact heart, kidney, and really most of the major organs in the body. So the finding with metformin is actually quite interesting, and it's based, as you can see, on some precedent. So age reversal effects. So let's get down to the nitty-gritty now. reduce the biological age across multiple organs and here in the frontal lobe of the liver, improved brain aging biomarkers. So it's actually improved the biological age actually by some period of time, reduced oxidative stress via the NRF2 pathway, has neuroprotective effect, again, reducing a number of biomarkers of neurodegeneration. And again, I guess you'll be familiar with amyloid beta and tau, proteins that have been linked to Alzheimer's for many years. Improved synaptic connectivity and neuronal regeneration. Clinical trials show mixed but promising results for cognitive function. So again, this is an old drug for type 2 diabetes that's been around since 1994, and here we are 21 years later finding these effects. Ongoing clinical trials are in this study, TAME, and I'll mention this in a moment, that has been funded by the NIH. It's in over 3,000 patients, but there is the need for research on sex-specific effect, such as females tend to have higher dementia incidence. So the golden question would be, well, does metformin show any positive effect in females that are either predisposed to dementia or at the early onset dementia stage? So this is the study, and actually this is taken from the TAME website. So targeting the biological of aging, ushering a new era of medicine. And I just wanted to give you the detail here to acknowledge the Wake Forest University, because this has been work funded by the NIH. As you can imagine, perhaps this work has to be funded privately. This is an old drug. It doesn't fulfill perhaps the criteria of being one of the new experimental drugs. So they're working through getting the study funded and getting this study conducted. And really, what it's trying to do is ultimately, and again, I love the infographic that's gone with this, proving that aging is treatable, targeting aging with metformin trial. This is what it will do. And studies have already shown, as I've mentioned, that it may influence metabolic and cellular processes. So I think that in its own right makes me think, well, actually, perhaps there is some mileage in looking at older drugs. Can we learn from these older drugs and start designing the drugs of the future based on what we know of the properties that of these drugs that have been tried and tested, albeit in different indications? Let's miss that one out. So again, just mindful of the time. So this is taken from one of the, I think it's taken from Medcom. One of the medical information leaflets is metformin, a wonder drug. Those are the preliminary effects associated with metformin, and I think that in its own right is really grounds for optimism, but there's no doubt that further work needs to be done. But again, early days, thinking about drugs that may positively affect longevity. So I'm going to mention a little bit about rapamycin. I said this at the start. So rapamycin is also a drug that's been around quite some time, used as an immunosuppressive, being studied for anti-aging, inhibits the mTOR pathway, and this inhibition, at least in animal models, has been associated with increased lifespan. And again, these are some of the positive effects shown in animal models for which there is a substantial literature base. So this isn't one study. All of these studies are based on a substantial literature base. So rapamycin, again, study conducted here in limited clinical trials, and I'll just show the effects here, mixed effects on the immune system. Side effects tend to be associated with infection risks, mouth sores, nausea and headaches. So you might wonder, not sure I'm going to take that as a daily supplement, and of course that's not the intent. But the intent here is to think about, are there properties, perhaps of rapamycin, that we could improve upon? Again, note, not FDA approved for anti-aging, remains experimental, but further studies need to be done around optimal dosing, which may reduce the adverse event profile and perhaps some of the long-term safety, and may, I think, give us the possibility that rapamycin should be used in an appropriate way at an appropriate dose by healthcare professionals. You know, again, it's promising that this is something that we can learn from. So recent clinical trials, so again, if you had early onset Alzheimer's, perhaps you're prepared to put up with the adverse event profile that I mentioned. You don't have a great deal to lose if it can slow down the progression of Alzheimer's. And again, with most chronic diseases, once they get to a point, again, of course, the patient, him or herself, together with their physician, needs to consider the benefit and the risk. But again, I would perhaps advocate that this is taken very seriously, because adverse events can be managed if they prolong not just length of life, but also quality of life. And there is a study here being conducted, as you can see, in San Antonio at UT Health, conducting a study on cognitive impairment in early stage Alzheimer's. So statins. So many people take statins. Statins, as you know, LDL cholesterol reducing agents. A large number of them are available as products, as generic products. I don't think you can buy them over the counter. In fact, I'm pretty sure you can't buy them over the counter. But these have been in millions of patients. Their safety profile is very well understood. Their ability to lower cholesterol as a surrogate marker for the prevention of cardiovascular disease is well established. It's a regulatory endpoint for cardiovascular disease. There's no doubt that statins have an effect as anti-inflammatory agents in addition to their effect on cholesterol. And as you can see, the possibility of using statins as in the dementia field are really quite, perhaps quite provoking when we think about the likelihood that dementia possibly affects well in excess of 50 million people worldwide. And again, for any of you, as I mentioned at the start, who have perhaps been part of seeing somebody who has dementia, you'll know again just how upsetting that is, not just for them, but for you, and anything that can extend their quality and length of life is probably welcome. So statins are neuroprotection, so there is a literature associated with the cardiovascular benefits, but also the neuroprotective benefits. And this particular study here that looked at a meta-analysis of 55 observational studies in over 7 million patients, which followed the PRISMA guidelines, I think is really quite provocative, showing that statins had a beneficial effect in patients with Alzheimer's. So this is the study here, and again, I've put the publication in for you, shown to may be linked to a 63% reduction in the risk of developing Alzheimer's disease. 63% reduction. That's a significant reduction if that turns out to be correct, and there's no reason why it shouldn't. It's taken from 55 observational studies in 7 million patients. 63% reduction, as you can see, taken for at least 3 years. That's really quite something. And I think as a potential agent, again, to increase longevity, I'd be quite excited by that, as I'm sure the statin manufacturers are, and they should be if that turns out to be correct. As far as I'm aware, the use of statins does not have regulatory approval for Alzheimer's, but I'm sure that that will be coming, or I'm sure that that will be being pursued. So dementia and the role of statins, key findings. So again, I've put this in for completion, just in case you want some of the detail. Lowering dementia risk, and those are the hazard ratios. Reduced risk of Alzheimer's, vascular dementia risk reduction. Group 2 subgroup findings in type 2 diabetics. And again, some of the references. So again, these are just for completion for you, but I would be quite positive around thinking of the use of statins in dementia. Implications and future directions. Well, I think it's probably obvious to say that this does have really some supportive evidence as a preventative tool. And again, when we're thinking about as we get older, and again, that won't apply to everybody here, but as we get older, and perhaps as we have that conversation with our healthcare professional, what are you thinking of? as you get older. If you're interested, it may be worth raising with your doctor, what do you think about the use of statins to prevent the onset of dementia? And, you know, it can't hurt. The doctor can say to you, actually, I don't believe it, I'm not going to prescribe it, or I can't prescribe it, or I do believe it and I can't prescribe it. But well, have that conversation and at least be aware that this research has been conducted. Clinical and research considerations, so I think these are observational study limitations, so causation cannot be confirmed. So of course this is a retrospective study from studies that have been done. These studies have not been conducted to understand the risk per se in a bespoke clinical trial. And I think the rest of the conclusion that you can see here. So I'm just mindful of the time. We've got a little way to go yet. I want to mention this about aspirin, because aspirin is something that featured in the news just recently. And again, just go through some of the background. So again, everybody's heard of aspirin. It's been around for many, many years. Widely used as an anti-inflammatory, and again, won't go through its mechanism of action because I'm sure you're aware of it, but really, aspirin inhibits COX-2, cyclooxygenase 2, and it's also showed effects on reducing tumor growth and vascularization. So in addition to its effect as an analgesic, reduces inflammation, which has been shown to increase cancer risk, and also the prospect of progression. So aspirin in its own right has been a very curious drug that has been around for many years, as I said, and I've spoken to many people in drug development who have said to me, you know, Martin, if aspirin was discovered today, it would be very hard to get it through drug development because it's actually quite hard to understand how it works. And that comes back to the perhaps maybe now a little bit outdated notion that we need to understand how everything works before we can take it through approval. And of course, the reason for understanding is perfectly valid because it's to guard against any of the side effects that we may see. And again, if any of you remember the story with celecoxib or valdecoxib, COX-2 inhibitors that were very effective in reducing pain, particularly in patients with osteoarthritis, they ended up getting withdrawn from the market because they had a very rare event associated with a vascular condition that unfortunately meant that those drugs were taken off the market. So there's no doubt that the regulatory process is there for a reason, and it's there for a reason to protect people, particularly when drugs get into millions and millions of patients. So why this is particularly interesting, so as you can see here, it's published just in January this year. Aspirin prevents metastasis by limiting platelet thromboxane A2 suppression and actually priming T-cell immunity or releasing the block on the ability of the immune system to combat cancer. And I think that this quote here, I mean, it's taken from the lead author, so he's likely to have some predisposition, shall we say. Aspirin has the potential to be less expensive than antibody-based therapies, well, yes, of course, and therefore more accessible globally. And the possibility of aspirin as an anti-cancer agent, I think, has to be taken seriously, and this is beautiful biology behind it. So again, if you're not familiar with it, because we are running out of time, please read the paper. I've left references here. But aspirin in its own right inhibits COX-1, but also thromboxane A2 suppresses T-cell immune responses, aiding metastasis. So that's what thromboxane does. And aspirin enhances T-cell function by blocking thromboxane A2. So that in its own right is quite unexpected. It really was I think, almost an accidental discovery, at least, that was portrayed in the popular media. And I think that in its own right makes you think again about the role of not just aspirin, but this particular pathway. And are there other drugs just sitting there waiting to be discovered? Or does this highlight for us perhaps a pathway that we hadn't appreciated before, where we may want to target more selective, more potent drugs that may induce these anti-cancer effects? So won't go through that, but again, that's there just for completion, just for you. And I think future directions, because I think these are important. Anti-inflammatory effects have been around for a long time. So I remember when I was at GlaxoSmithKline, one of the things that we were looking at was the anti-inflammatory effects of a number of COX-2 inhibitors in cardiovascular disease. And of course, we had aspirin as our gold standard of care, something that you had to beat, which was actually very tough at the time and very challenging then for drug discovery, because aspirin is very cheap, of course. The possible synergy with other longevity promoting interventions, of course, is there. What would you find if you were to combine aspirin with any of the others? The senolytics, perhaps, omega-3 fatty acids, vitamin D, the list, could get very long. The possibility, I think, of current challenges and considerations really needs to be looked at the individual level, because, of course, there is a risk associated with aspirin, and you probably already know this, the risk of GI upsets, for example. Some people can tolerate aspirin, some people can't, and the need for further trials. So I think the takeaway message for me is that by perhaps this unpredicted mechanism of action that is driving immune protection of the body and enabling cancer destruction by really marshalling the immune system, could offer some potential benefits for longevity. And that in its own right, I think, is quite informative, and it's quite exciting that it was published just 2 months ago. So just for completion, I want to finish on caloric restriction and metabolic interventions. So the effects of calorie restriction on animal models, well, reducing calorie intakes, I think that speaks for itself here, that you are what you eat. I think we probably all know that. That's where I started off at the start. If you have a bad diet, then if you have a bad diet every day or every week or every month, then you know what the consequences are going to be. We all know that. It doesn't stop us doing it, but we all know what it is. So effective caloric restriction, and I think any of the dieting regimes there are around are worth consideration. But again, obviously from a longevity perspective, that needs to be taken into real consideration and preferably discussed with a dietitian, if not your healthcare professional. I think we need to be a little bit careful here on following the latest caloric restriction news that there may be around. Role of NAD boosters and saturators, haven't had time to describe that, but there's no doubt that there is a role here for nicotine adenine dinucleotide boosters, and again there are some potential agents that can do that. Metformin and rapamycin, well, I've mentioned those. These drugs actually mimic caloric restriction effects in addition to some of the properties that I showed you about a few minutes ago. So the microbiome and aging, well, of course, microbiome is a very topical area as well. And again, for those of you familiar with it, it's you are what you eat. The microbiota in your GI tract, and your lungs as well for that matter, but certainly in your GI tract, are a consequence of what you eat. And actually there's some very interesting research that's been conducted on the effect of some of the rheumatoid biologics on how they influence the microbiota. So the microbiome in its own right, and the balance of gut bacteria as it changes with age, is something that, again, we need to think about as we get older. So this is part of the multifaceted biological process. Again, with longevity research, as you can see, it's not a simple, this is how we can increase longevity. There are many things wrapped together. Probiotics and prebiotics for longevity, well, they go without saying. I won't mention those, but recent studies linking gut health to lifespan, there's been many studies conducted on those, particularly by nutraceutical companies, of course, and some quite compelling evidence, I think, that the microbiota and the preservation of microbiotal populations is critical for gut health. Perhaps no surprise, but it's nice that it's being put on a scientific platform. So commercial activity and opportunities. So as you can imagine, this is an enormous business. And there are, I'm going to give you a little bit of an overview of key players in the area. So multiple biotechs are investing in anti-aging therapies. Of course, it's probably $1 trillion business when you think about it. Who doesn't want to have something that allows us to have that definition of longevity, longer life and longer quality of life? And notable company examples, there's a couple here, GENIXICONSULTIng in particular. So GENIXICONSULTIng is actually now headed by my former boss at AstraZeneca, Richard Marshall, who's really overseeing multiple anti-aging technologies. And as you can see here at the bottom, well, billions are being invested in this research. And these are just some of the companies, some of the many companies that are involved in longevity research. And some of these you may be aware of, and some of them you may not be aware of, but this is just a snapshot. There are many more, I can assure you. But these are the 20 best funded startups in longevity research, and I'll miss that bit out. So future perspectives and challenges. So I do want to finish on just a couple of things, because these are important, and I'm sorry, I know we're running a little bit longer. I'm surprised I still keep my voice, actually, but we're running a little bit longer. So the ethical and societal implications. Anti-aging therapies really, they raise questions about accessibility, but they also raise questions about global sustainability too. And I'll come on to that in I think it's the next slide. Many limitations are there because some of these therapies are still in the experimental stage, of course, and I've mentioned that as we've gone through, and there are some promising directions for the future that may include single agents or may include agents in combination. And this is the part that I wanted to put in because, again, this is something that I think is really close to my heart, and it ought to be close to everybody's heart because it is a fact. This isn't fiction, this is fact. How the global population is increasing and how it's predicted to increase in the years to come. And whether or not you believe what's going to happen after 2025 is actually to an extent irrelevant, because it's what happened before 2025 that's fact. So the very fact is, because we're all living longer, and we are living longer, hopefully, with a healthier lifespan, the world's population is increasing, and that puts greater demand on keeping us all happy, and feeding us, and giving us houses, and everybody wants cars, and go on holiday, and everything else. So that it puts a big strain, if you like, on global sustainability. Now, that doesn't mean to say, of course, that we shouldn't promote longevity research. Of course we should. But hand in hand, we need to think about responsibility to the global environment and maintaining that global sustainability. That's absolutely essential. Otherwise, if you like, we will not be able to support an ever-increasing population. And the global population, well, if you look at the annual number of births and deaths, this is the predicted number of births that looks to be decreasing as we increase, but that nevertheless doesn't diminish the fact that the world's population will increase. And I think it's around 8 billion as we stand today. It's projected to be 10 billion by 2050 and even beyond that. So that's a sizable increase in the world's population. And again, that doesn't include the effect of any possible therapies that will increase longevity. So there is the population of having, I think, quite a global burden as we all live longer with a healthier standard of life. So just by way of a summary, and this is now nearly my last slide, hopefully I've shown you that some anti-aging research, it spans multiple fields. It is multi-process, it is complex, there is not one simple solution. It spans our diet, it spans our genetics, it spans an understanding of cell biology, microbiome research, and it also involves really tried and tested drug discovery and drug development, but perhaps some experimental ways, particularly in accelerating the regulatory process through the need for the development of surrogate biomarkers. The potential of combining therapies, as with every disease, is there. Of course, it makes perfect sense to combine one with another if they're targeting different processes. So it gives us perhaps a toolbox that we could start to explore and maybe use some of the epigenetic clock markers as surrogate markers in mechanistic clinical studies. And future research really requires continued investment and collaboration across the disciplines, but also making sure that we maintain the requirements for maintaining global sustainability, because the rewards are huge for finding agents that will prolong longevity, but we have a duty, I think, as society to make sure that that's done in a responsible way. So I'm going to finish there. I think I have put in, just for completion, a few additional references for you. So I'm sorry if we've got a little bit over time, but hopefully you found, if not all of that useful, some of that useful. It is, as far as I'm aware, pretty much up to date until this morning, but I hadn't got time to put that other study in. And if I can, I'll be delighted to answer any questions. But one thing I do want to leave you with, because I'm an extreme sports enthusiast, and I actually love downhill skiing and scuba diving, in particular wreck diving and cave diving. I was wreck diving last year, probably one of the most challenging wrecks that I've dived off the southern coast of Madeira. And it never ceases to amaze me, having managed to navigate my way through this wreck with, of course, a dive group and come back up. The first thing that people do when I get up to the boat is they light up a cigarette. And this was one of the dive instructors. And it astonishes me today. So skiing in the Dolomites in just last month with my son, I'm astonished by the number of people. You're in beautiful alpine air, and guys light up cigarettes, and women. It's not just men. Men and women light up cigarettes. So while I was at Stansted Airport yesterday, I got there a little bit too early, and because I'm working on training for some events later on in the year, I thought, well, this is my chance to get some steps in. So I was walking up and down outside to boost my number of steps. And of course, if you want to smoke in Stansted Airport, like everywhere now, you have to go outside. So there's these designated anti-smoking areas. And I was walking up and down, and I thought, you know, I may as well smoke because there's so many people outside smoking. You can smell it all the time. And I'm looking at the people who are there, and they all look really miserable. And I'm thinking, you know, you don't look as if you're enjoying yourselves to me. And so, you know, I think, again, we have a way of thinking within our brains, which is that perhaps a relief of stress is to do something bad to our bodies. And in this particular case, it's smoking. Perhaps it's to overcome a nervousness or anxiety about flying or whatever it may be. But I think we know deep down what's good for us and what's bad for us. I think it's really important that as society, as we move forward and as we help generate information to educate the next generation of people, whether it's our friends, our children, let's bring them up in the way that we were brought up, because a lot of what we do can help us. And yes, we need new therapies, we always will do, but let's not forget some of the things that we know today. So if you smoke, please stop. If you don't smoke, please don't start. And if you vape, you know, spend your money on something else. Go to a gym or something like that, or go out to eat. Because there is, I think, a way that we can help ourselves too. So I'll finish then on that very inspirational message. Again, answer any questions in the time that we've got left. So thank you.